Hello, everyone. Thanks for joining us. This is our inaugural session of this brown bag that we're going to be hosting here, hopefully on a monthly basis in entomology. The idea here is that we're going to try and cover some timely topics for everyone to just for general interest, but more importantly, to assist you in what we perceive as some things that might be coming down the pike on the extension side, questions that you're likely to encounter, and then we'll open up. We'll start with that, and then we'll open up the floor toward the end of the session with just any general questions that you might have. So there are a lot of entomologists on the Zoom here today. So hopefully we can handle any questions that you're thinking of. So today we're going to be talking about delusional parasitosis. It's a pretty interesting subject. I'm sure, or I'm almost sure, that most of you have encountered this issue on the extension side. It can be a difficult issue, and we are lucky to have someone who is quite the expert in this area. Grace Kolb is a Ph.D. student in the department, and this is the focus of her research. So she's going to be up first to give you sort of an overview of the landscape here and what she's learning from her work in this area. And then we also have Dr. Andrew Johnston, who is our insect diagnostician and clinical professor here in the department. And he's going to share with you some thoughts in terms of the kinds of inquiries he gets and talk to you a little bit about those things you're likely to encounter when dealing with these cases. So, Grace, I'm going to turn it over to you, and we can go ahead and get started.
All right, can you guys all see my screen okay?
Give it just a minute. I think it's coming up. Looks good.
Great, so we'll just jump right in. As you guys are aware, these are really, really difficult pest consultations. Pretty much it's trying to decide, is there something that's hard to find or is there actually nothing there? So we'll just dive right in here. Understanding difficult pest calls, like Dr. Richmond said, most of you have probably received a call about a mysterious biting or crawling pest. But what I want to sort of focus on today is a little bit of my research, but mostly how can we recognize if it's delusional compared to if there's just nothing there? And how do we respond and stay within our professional role and expertise? So just to start with, delusional parasitosis is a psychiatric disorder diagnosed by medical professionals involving the fixed belief that someone or their immediate environment is infested with bugs or parasites when there's no evidence to support this. It's considered a somatic type delusion, which is like a misinterpretation of your body. So, for example, anorexia is also considered a somatic delusion where people think that how they interpret their body as being maybe very thin or underweight when that doesn't match reality. In these cases, though, it's complicated because clients actually are feeling very real sensations. And in some cases, they actually are seeing the pest and having visual hallucinations. So when you just say, I don't see something, it's not quite that simple. You might have heard this called by other names. Ekbom syndrome used to be one. It seems about every 5 years, doctors change the name of this. So Ekbom syndrome, because it was first described in the 30s by Carl Ekbom, who was a Swedish doctor. However, he was kind of special and he actually named two different disorders, Ekbom syndrome. Ekbom syndrome 1 is restless legs, and then he was like, let's just name it after me again. So to kind of separate the two, this one's not usually used. Delusions of infestation tends to be what doctors prefer right now. However, that includes like infestation with anything. So if I think I'm infested with aliens, that is part of this umbrella. However, those individuals are probably not contacting us as entomology or extension. So that's why we sort of prefer the delusional parasitosis to sort of, yeah, because those are the people who are contacting us, ones with parasite type concerns. You might have also heard Morgellons. That was the belief that people are infested with fibers. The CDC did a huge investigation in the early, like 2011, 2012, 2013, and has not found that fibers seem to be a real thing. So that's also not exactly the same type of disorder. Right now, doctors aren't diagnosing things as Morgellons. That's more people taking it upon themselves and Googling their symptoms. So clients feel these sensations, and these sensations are real. What it actually is nerve irritation. The medical term is formication, out of like, it feels like ants, that crawly movie sensation. Lots of things can cause this. Some of the bigger ones we've been finding are medicine interactions, because most medical drugs are tested alone. So there's not a lot of research into what happens if you're taking a statin and a diabetes drug and something for, a heart condition. We found lots of medical conditions are actually causing this. So kidney disease seems to be a huge one. UTIs in nursing homes are a huge one. Parkinson's seems to be caused by it, that there's brain signaling stuff involving like estrogen levels and dopamine levels. And stress or trauma seems to also be a trigger. So probably a better way to look at this is not its own disorder, but rather like a symptom. So you go to the ER and say, I have chest pain. They're not going to say just, oh, yep, sure you do. Instead, they're going to say, are you actually having a heart attack? Are you, did you break a rib? Like, what's going on? And we're starting to realize that doctors need to be investigating deeper, because there is probably an underlying sensation. When we look at who's affected, it's mostly older women. Older women is kind of the like stereotypical case. It seems there's a peak between like the 20s to mid 40s, equal men and women. That's usually caused by drug use, like cocaine bugs. And then over the age of 55, it's mostly women. So like 2 women for every man is what we're finding in our work. So these cases, though, are a bit complicated, because clients can describe or draw the pest. They can describe its life cycle. A lot of medical providers don't have detailed entomology training, so a lot of them don't feel comfortable actually ruling out an insect pest. A lot of these clients will bounce between providers if they don't get the answer that they want. It's not because there's no pest, it's because you clearly don't know your job. So they'll find someone who does, who they think will tell them what they want to hear. And the bigger underlying cause is it's very hard to say for sure that nothing is there. However, if you sort of look at the big picture, these cases are a lot of like an investigation. So some indicators that it might be delusional and it might not be a real infestation include if only one individual is getting bit, and there's more people in the household. So if it's bed bugs, you would expect, both people in the same bed to be getting bitten. But if only one is, that could be an indicator. We've also found a huge indicator is a recent major life stressor. So the death of a spouse, retirement, divorce, death of a child, those seem to be huge things that kickstart it. A lot of times these individuals can tell you like the day or time that they first noticed the problem, where in real infestations, generally it's kind of more vague. These people usually have a lot of social isolation. They can quit their job. They can be fired from their job. They maybe don't want to have visitors over because they don't want to infest them. Another indicator is if multiple people have looked at it and they don't find anything. So if the person comes to you and says things like, oh, I went to 5 pest control companies and they found nothing, or a doctor, they found nothing, that's an indicator. Unsafe pesticide usage, we find people are doing all sorts of creative things to get rid of the pest. However, because none of them work, people can be using unsafe insecticide dosages. And finally, the specimen sign, that's when people give you samples of what they think is causing the problem. However, the samples usually don't have anything. So we had done a really cool work where we looked at 150 doctor diagnosed cases, and the specimen sign was present in 56 of those. And for the most part, we find people are giving physical samples or photographs. And if a specimen sign is there, that's a huge help, because you can actually evaluate what's in it. we found of the ones submitted, a lot of times there's no arthropods, but when there are, they're not exactly things that we would expect to be infesting people or biting people. But this is where your entomology knowledge really comes in of, okay, there's maybe a midge that they found on their windowsill. Is this something that actually could be causing a problem or not? And then back to sort of pesticide usage, we in our study found that there were actually pesticide usage coming from all sides. We found doctors were actually prescribing different insecticidal products, even when they said that there was not a pest, partly due probably to patient pressure. And I want to note here ivermectin, because that's something that people can overdose on. And in our research, somebody actually did. And then also people themselves are using all sorts of interesting compounds, including like camphor on their eyes, which cause blindness in multiple people. We had one person taking baths in malathion every day. People doing bug bombs and then not airing out their house, boiling water, pretty much a lot of self-directed dangerous behaviors. So as far as what do we do though if someone comes to us, you want to focus on your expertise. So listen to the concerns, evaluate if there's an actual pest, and make sure you document whatever you observe. We want to avoid confirming a pest if there's no evidence. So if you're talking to them, don't say things like the pest or your pest or the scabies or whatever. Kind of just stay real general. We want to redirect somebody towards medical attention, if appropriate. Oops. And we want to make sure that we communicate with our colleagues if it's something that we don't feel comfortable handling ourselves. My background was in medical entomology, and this was not covered at all in any of my undergrad entomology or my master's program in entomology, which seems like a surprise when you look at all the people dealing with this. If you get a specimen sign, usually they're very well packaged. If it's like a baggie and a Tupperware, and usually very detailed and labeled. So you can accept a sample if it's safe and appropriate. So for example, people can give you bodily fluids. You don't need to examine spit, tears, pee, poop, blood, any of that. That is not our thing. Most samples, when we looked at what actually was in them, it seems like a lot of dust, lint, skin flakes like scabs, fibers. And usually at that initial phone call, we want you to set expectations early. So say, I'll only evaluate 5 samples or something. Otherwise, you can sort of get roped into someone sending you stuff over and over and over and over when there's nothing there. We recommend when you talk to clients, acknowledge them. So you could say something like, I see you're really suffering with this. You can use language that reflects what they're saying. So if they're talking about the itching or the crawling, but we want to avoid words of like the pest, the parasite, because that sort of can feed into, yes, there's something really there. We can reassure them and say like, I've worked with other people with similar symptoms. And it can be helpful to see if the client has an open mind of, I can look at your sample, but sometimes these symptoms can be caused by non-pest causes. If they're open to that, awesome, there's a pretty good chance that they can actually be treated. If they're like, nope, we have to find the cause, then that can make treatment very difficult. And then focus on moving on. So you can say things like, what matters most is that we help your suffering, or, we want to at least help you feel better, even if we can't find what's actually causing this. If you think that there are no pests based on the situation and what you've found, you can gently encourage a medical evaluation. What you can say are things like, your symptoms are real, but my expertise, fall back on what you're good at, is entomology. Since I didn't find anything, that's all I can do, but possibly a doctor may have different tools. And a dermatologist, if they wonder who to go to, is your best bet. 80% of dermatologists have seen a case in the last 5 years. Prognosis, they have found that early treatment within the first 3 to 4 months of fixing whatever the underlying medical cause is can lead to full remission. If instead they've been suffering this for like 2 years, they're probably always going to think they're infested. Even if they're treated, they'll say something like, oh, the parasite's just quieter, or it doesn't bother me so much, but it's still there. Treating that underlying cause does often resolve the symptoms. So pretty much where we fit in is in that initial, how do we rule out a real pest? And then how can we focus on reducing harm? So maybe saying like, if it was pet, if there was something the insecticide you're using would have killed it, let's dial back on those because those are causing you other harm. Focus on your expertise, and then guide clients towards care. Or if you're not comfortable evaluating insects or things, guide clients towards Purdue, which Dr. Johnston here is going to talk about shortly. So that's what I have for now. I'll stop sharing and we can move to the next section.
That's great. Thanks, Grace. I guess I'm going to ask Andrew to go ahead and follow up, and then we'll open the session to questions on this matter.
Great. Yeah, so Grace gave a fantastic rundown of everything. I'm going to reiterate a few of those points and talk a little bit more about kind of the practical, what do we do as Purdue Extension to deal with these, right? And so first, it might be helpful, what are the actual things our clients could be dealing with if it isn't delusional? And so these are the main culprits, right? Mosquitoes, we know them very well. They're mostly outdoors. Yes, they get indoors. These insects are visible. They can't persist indoors. They might come in one or two, but we can usually figure out that it's mosquitoes if that's the case. Chiggers, you usually don't have the actual chigger. These are kind of tick-like mites that get on the skin and will leave kind of this pattern of bites, typically on legs or lower abdomen. You only get these outdoors. I think a lot of us are familiar with these, so that could be something people experience, but usually people identify that pretty well. They know what chiggers are. Somebody has seen that before. Bed bugs, obviously, it's everywhere in our state. These are common, but by the time they're a big problem, usually they can be found, right? Your pest control companies that they're calling in are going to find bed bugs, probably, if they're looking for them, right? The big question mark and what a lot of people point to then are bird mites. And there are some other things that can bite you, but these are kind of the big ones. Bird mites can be a big problem because these are tiny, tiny things that you can't really see, that are hard to collect and detect, but this is rare. And in reality, they're only going to be a problem if you have pigeons or swallows or something roosting in your attic. That's when you might end up getting some bird mite issues. So these are the common things to look for. You've probably had some experience with some of these. Does it sound like one of those or not? Right. But, as Grace was mentioning, this is really common. So I did a little count. So last year I dealt with 316 inquiries, and this is everything across, ornamental plants, pests like cockroaches in the home, all over the place. But 10% of these inquiries were what I consider to be delusional parasitosis. There's no insects. People are reporting bites or infestation of their bodies, of their homes. So this is quite common. And to kind of reiterate again some of what Grace was saying, these are some of the telltale signs that this is probably not an actual insect or mite. The stories are oftentimes complex. The facts can change, right? They are trying to explain these symptoms, but they don't actually have good facts. So a lot of times that story is really kind of everywhere and hard to follow. Oftentimes, if they're talking about this happening everywhere, it's in their car, it's in their home, it's at their work, right? That's probably not an infestation of something because it's they are the common denominator, right? Grace mentioned samples. A lot of times we get samples packaged in a lot of different things. If they have a lot of samples, they come in with a whole box full of a lot of different baggies, but there's no obvious insects in them. Yeah, it's probably this every time. Also, we get a lot of people talking about that these insects live under their skin. We also get a lot in orifices, in their mouth, in their ears. We don't have insects that live in those areas, right? So if they're talking about these types of things, it's probably delusional. Also mentioned that I've seen a lot of upticks in these cases either in the middle of the summer or at the start of the winter when the weather changes. All of a sudden, it's hot and humid. Your skin starts to itch. Maybe, it increases these issues you're having with whether it's drug interactions or whatever else. Same thing when it gets cold, you start itching. People get it. Super mild trigger warning if you are eating lunch right now. So these are just some pictures of samples that have come in. They usually, as Grace mentioned, are flakes of skin. They're scabs. I've looked at a lot of boogers. That Petri dish are all boogers that people pulled out of their nose. And they can be quite gross. And this is one thing I mentioned. If you get like this collection of samples in, because I think that deep down they know something's not right. They can't find the insects, but they're convinced they're there, and so they're sampling everywhere. That's another sign that clues me in that this is oftentimes delusional. But again, how do we respond? Reiterate that we do not provide medical advice, medical treatment, right? We can identify pests, we can provide control recommendations for pests, but not medical treatment, right? As Grace mentioned, super important, acknowledge their symptoms, right? They are experiencing this, and they are looking for help, and they need help, right? But be firm and confident in that communication. Now, for those of you who are not in the entomology department who have that specific entomological training, please just refer them to us. Send them to me through the PPDL, the Plant Pest Diagnostic Lab. Either have your clients submit the samples themselves, or you can submit them on their behalf. This is probably something where it's a lot easier for me to respond because I am confident in all the possible things it could be and what is not indicated in their samples and in their explanations of their symptoms. So maybe that makes it easier for me to, write a confident report back to them. I also think getting that somewhat official report back from our system and their email that, looks official can kind of help I don't know, kind of reinforce our message back to them that, hey, we have done everything we can do. You need to go see a doctor. So please send them my way. But that's everything I just wanted to touch on briefly again there. And if I can figure out how to stop sharing, I will. But if there, I think we can go to
Yeah.
the discussion.
Yeah. So everybody's welcome to enter any questions they have in the chat. I see we have one, but also if you just want to speak up, that's fine as well. So we have one from Sherry Jansen here. Bird mites, are they found in backyard poultry flocks?
Yeah, and that can be a problem. That is, yeah, absolutely. So if you are working in a poultry situation, you have some of them, they can exist there. But again, usually those are very clear from the descriptions. The mites can sit on you and follow you, but they're not going to complete their life cycle on a person. They have to be on birds. So yeah, that is definitely a place though where that's where you're going to get the bird mites.
Other questions? Comments? Okay. Any general questions, things that you're seeing that are of an entomological concern that we can help you with while
Doug?
we're here? Yeah. Yes.
Sorry, I put in there. So, because I've actually already dealt with this year, and I'm curious, what other doctors are you actually like saying, like, because mine had already been to a dermatologist, a family doctor, and I know we can't obviously go see a psychiatric doctor, but like, who in general, and also just a clarifying point, PPDL, because I've already dealt with it this year, they won't take it if it's like they might take like if you pulled it off in the human hair, but they're not going to take anything human samples. They will only take fibers and stuff like that from the environment. They're very stern on that.
Yeah, and I might add on that PPDL side, we try to do that because we get really gross samples submitted through there. But we will look at whatever I will look at whatever gets routed to me through PPDL. So they do send them in. One thing you can recommend people do is to take clear packing tape and use it and say, oh, well, maybe you do have something, and you can kind of like you were lifting lint off of your clothing or furniture, do that around their house, and then they can fold that packing tape in half to cover the sticky sides in between, and they can mail that in. So that's an example.
Okay, that's good to know.
Yeah, but you are right. We don't want people will try to pull out like chunks of flesh sometimes, and we definitely don't want to deal with that. And doctors, I don't know, Grace might have some other advice for that.
Yeah. So as far as the tape goes, that is actually what dermatologists and doctors, their protocol recommends that. And tell the person of like, oh, whatever part of your body is most affected, put it there. That way you're not getting, like you said, chunks of stuff or, baggies of spit or stuff like that. But you could still sort of evaluate. Doctor wise, it's hard to find doctors because they're not actually really trained in this disorder. So your best bet will be a dermatologist just because they would be more familiar with dealing with people with this. So they'll at least have probably heard of it. However, we have found that most patients in our 150 people study, on average, they did see 3 doctors before they were actually diagnosed. Dermatologists also can be good at ruling out or giving suggestions of like, maybe it's actually dry skin or something like that. And they can have better luck either prescribing medications or sort of sending someone on to an actual specialist. And your point about not recommending a psychiatrist is right on. Most of them have never dealt with this because the people are very sure that they are not crazy. If you hear that a lot, like they're very insistent that it's not in their head, that can be an indicator of this. So your best bet would be a dermatologist, rather than even a family physician or anything like that.
Might
And
also add to that, one thing we sometimes try to do through the PPDL, if we get these people who are very persistent and think we've missed something, is after the first round of samples, we'll say we'll only accept samples from a doctor. So sometimes maybe that way the doctor can collect the samples, send them to us, and then we give the report back that's very clear there's no insects and we don't think there's insects, and maybe that can help clue that doctor into the fact that this is something else going on. But we've only had that feedback work once or twice over the last 2 years, but that's something else we tried.
So Andrew or Grace, Fred Whitford with the pesticide programs. And so going back to lots of different jobs over the years, I have empathy for people. I listen to them. And what you'll find that if you listen to people, then they keep coming back and coming back and coming back and coming back. And that makes it hard because eventually you start repeating yourself, and not to be rude, but you end up saying, I can't help you anymore. You need to see a physician, you whatever. So, appreciate the fact that if you listen to these folks, they've been around everything, and it makes them very difficult if you listen to them and interact with them, I guess. It is difficult to get out of that situation without being not rude, but you know what I'm saying? It's just saying, I can't help you anymore. I, I can't do nothing. And that is the tough thing to this one here, is just the repeated call. I know you said this and I checked that, but look what I found, and look what I found. How does that? Yes. So, long and short, it's a difficult process if you listen to people and have empathy for them.
That is so true. And again, this is where refer them to the PPDL if you haven't already, because maybe that's a second voice to reiterate what you've already told them, right? I, I don't know. I've had pretty good luck with the reports that I've been delivering recently. I've gotten better over the last few years. I think in like what Grace was saying, acknowledging their symptoms, and then because this is kind of my expertise, I can write a lot of details in there that I think sound sciencey and official enough to them that maybe it gives them some reassurance that, you know, this was taken very seriously and there really isn't anything in the samples they're collecting. Doesn't convince them there aren't insects or pests that they're infested with, but at least that their samples don't have anything. But yeah, let us help you in that if we can.
I think another point is also when you have some of those initial calls is to set expectations of, my expertise is insect pests. I didn't find ones like this. I can't help you anymore at this point. But I know that that's not easy. My mother-in-law actually had the condition, and I don't think she ever believed I was actually an entomologist, because I didn't see what she was seeing. But sometimes setting those expectations and understand, yes, they reached out to you, but these people are very resourceful. So if you can't help, it's not like they're now stuck. They will keep trying to find other places, and maybe at some point they will get to a medical professional. But sort of if you keep getting dragged into looking at things when you've already said that there's nothing, that's not exactly helping the person, even though I know it's very, very difficult to sort of say, like, I've reached the end of my knowledge. And that's where the expectation.
There's times, Grace, that a physician, to get out of their problem, will send them back and say, this could be an insect, this could be a spider, this could be whatever. And so what they do is just circle back around, and here we are once more, right? Where that's the physician telling them that, and who might have contradict a physician? So there is no easy answer, is what you and Andrew are talking about to these things. If you listen to people, right, and
Yeah.
you feel for them,
And they do get cycled because for us, it's too much of a medical problem for us to solve. For the doctors, they're not always sure. So maybe it's too much of a bug problem for them. So right now, at least, it is in a very tricky place where everyone's just getting cycled through. We are in the process of starting to get a network of doctors who could get referred to or who do understand the condition. But that's only just now starting to get the process of up and running. Hopefully in the next few years, we'll start to have actual resources we can say, hey, these are doctors who know what this is, who you could easily refer to, who could handle it the right way. But that's not up and running at this time.
There's another interesting question in the chat from Michelle. Is there any way the entomology department could offer training that had CEUs for doctors so that they could take this training, especially general practitioners? What are your thoughts on that?
Doctors are very special. They don't like to listen to us, and they have a lot of really complicated stuff as far as how to qualify for their CEUs and how many, and who is qualified to actually give those. So right now, the University of Tennessee and the Southern IPM Working Group is starting to sort of try to create some doctor resources. But at this time, they are not, for the most part, besides two of them, one in England and one in California, they're not talking really to us or listening to a lot of our training ideas. Right now, most doctors say that this condition is so rare that we can't study it. However, as Andrew said, and all of you, I'm sure in your experience found, it is not the case. So hopefully in the next couple years, we'll start to get more communication, but right now that's not going on and there's not an easy way to fix it.
Yeah, it sounds like we're going to have to clear some hurdles. Did you want to add something, Andrew?
Yeah, not necessarily on the doctor front, but I do think we have an opportunity here to maybe add some CEUs for some of our pesticide programs and pest management trainings, because again, this reinforcing idea, if they call somebody who comes out and says, well, I can't find the bugs, but you're explaining bites, so you must be infested, and then they'll spray, which reinforces which one maybe is making their situation worse. Maybe they're going to feel those symptoms even stronger, and it's reinforcing the idea that there might be something there. So, yeah.
Good question, Michelle. All right. So you probably noticed I posted a poll. We're all extension folks. We know how this goes. So if you haven't filled out that poll yet, I welcome your feedback. And if there aren't any other questions, I won't keep you any longer. We
I do have
will.
one more question for the
Yeah,
first
sure,
presenter. Sorry.
Nikki.
I think that I heard you say try not to ever refer to it as a pest. So you're meaning like when they're saying it is, oh, I've got this insect. We shouldn't say ever insect. We shouldn't say pest. We should always try to refer to it as like the problem or what you're dealing with. Things like that. Weasel words is what I would otherwise call it. That's what you're saying. And do you have
Yeah.
suggestions?
Yeah, usually I would try to stick more with like the specific sensations they're describing. So whatever is causing, the crawling or whatever is causing, however you're feeling. Because if you do say the words like pest or, oh, the scabies or the parasite, these people, for a lot of times, if they hear like one little indicator that you maybe think it could be that, they really can latch on to it. And sort of like Andrew was saying, the whole thing of, oh, well, so and so said that there was a pest and sprayed. We want to kind of avoid that because the more that they circle around between us and pest control rather than getting the medical help they need, the more likely it is that they won't be able to get the actual treatment that they actually need.
And I might add to that too, right? I think the academic, extension kind of person to me wants to give as much information as possible sometimes. So I'll even run through, oh, here's all the things that bite people. And that was a mistake when I did that a few times because now they have, 10 new things to go research and think that they might have. So being careful in, in how we say that of, getting information from them saying we have these resources to look for what might be causing your issue, to see if there is a pest there or something like that, anyway, it's a little bit different than how we sometimes deal with other inquiries and clients.
Well, okay. I'd like to thank Grace and Andrew for the presentation today and dropping all this knowledge on us. Really nice work. Thanks to both of you. I will have this session recorded and available to those of you who are interested and your colleagues who were not necessarily able to attend. So the next session is going to be on March 24th. We're going to have Dr. Crystal Hans with us to talk about New World screwworm, which is a sort of a re-emerging issue and something that I think you're likely to encounter some questions on here in the coming months. So until then, thanks for joining us and have a great rest of the week.
Hey, Doug,
Yes.
I don't see, did you do a calendar invite for that March 24th one to all of us? Maybe
No,
I did.
not yet.
Okay. I liked that, by the way. Those are always nice because then I don't have to input it myself.
Yeah, absolutely. I feel the same way. I'll get one out probably, well, sometime this week. Okay, Nikki?
No, that's fine. I was making sure I didn't miss it because I do have appointments that day. So it might have been why I didn't accept it.
Oh, I see. Yep, we'll be
So,
at noon on the 24th.
okay.
I'll send it out system wide.
Thank you very much.
All right. Thanks for joining us.
No problem.